Hello, friends. This is Patrick Georgioff, trauma and acute care surgeon at Duke University, and today we are talking CT scans. Now, on your surgery rotation, you will quickly learn that CT scans are the workhorse imaging modality for our patients. In fact, most surgeons really do love a good CT scan. In fact, we look at so many scans over time, the surgeons become quite adept at interpreting their own images. Now, if you want to dominate your surgery rotation, you really should learn how to read a CT scan. It's not only useful in surgery, but for so many other specialties as well. And to that end, we recommend you look at as many scans as possible. Now, to get started, try reading the radiology report first. Then go to the scan and see if you can match up the findings. Once you've done that a handful of times, we recommend looking at the scans first, then seeing what you can find, and then checking the radiology report. If you do this enough times, your pattern recognition will definitely improve, and you too will be reading CT scans with the best of them. So today, I'm going to take you through a practical, easy-to-follow crash course on how to read CT scans. Now remember, a CT scan uses X-ray beams that rotate around the patient in a circle. The X-rays are absorbed by the body at different rates depending on tissue density. A detector then senses X-ray strength, and a computer uses this data to create detailed 3D images of the body. Now, the scan you're going to see the most in the general surgery world is one of the abdomen and pelvis, so we'll focus on that today. The scan extends from around the level of the heart to the upper thighs. And the vast majority of image viewing systems are similar to what we're going to show you today. You'll typically see a menu of different images, including the scout films and reconstructions in the axial, coronal, and sagittal planes. The scout film is also known as a topogram and is a quick and dirty shot that's acquired before the actual CT scan runs, and it provides an overview of the area that is going to be scanned. It also helps plan scan windows. Now, don't forget, the scout film can actually be useful, especially in the setting of trauma, where you can take a quick look at the whole body and identify fractures. Now, the axial, coronal, and sagittal planes can be confusing. Remember, the axial plane is the transverse plane. It's like cutting through a loaf of bread, and it's the shortest of all the cuts, while the coronal and sagittal planes slice the body from the head to toe and are longer cuts. The coronal plane slides from front to back or back to front, and the sagittal plane slides from side to side. In general, you should look at least two different views every time you look at a scan. The most commonly used are the axial and coronal images. The sagittal view is used less frequently, but it definitely can be useful when looking at the spine, aorta, and the diaphragms. Now, for the rest of the session, we're going to focus on axial and coronal planes. Now, another key point when it comes to CT scans is understanding contrast. Most commonly, contrast is given intravenously and or orally. It can also be administered per rectum, into the bladder, and into drains. So let's start with IV contrast. This uses iodine, which is highly absorbed by X-rays. In general, contrast is preferred for most scans as it enhances visibility and can better delineate structures and highlights the abnormalities within those images like tumors, infections, and can highlight blood flow. Here's an example of an abscess. And here's contrast extravasating from a lacerated liver. Now, one controversy you might come across during your rotation is whether or not iodinated contrast harms the kidneys. Beware, this is a heavily debated topic, and there are many folks that have strong feelings about it. Bottom line, contrast may or may not cause kidney injury. Until we know for sure, though, beware that you will need to consider how much value contrast adds to your patients if they happen to have bum kidneys. Now, IV contrast is administered via the vein, typically via a peripheral IV that is at least 20 gauge in size and placed in an antecubital fossa or more proximally. This caliber and location is necessary to achieve high flow rates needed to inject the contrast. If a central line is being used, they must be labeled power injectable, meaning they can withstand high pressure without blowing out. So the IV contrast goes through the vein and immediately to the heart before making its way to the arterial system, then back through the portal and systemic venous systems. That means that depending on when the scan is performed, you are going to be able to better see the arteries, veins, and certain organs better than others depending on the timing. You'll probably hear the phrase arterial phase, which is about 30 seconds after the injection of contrast, or maybe even portal venous phase, which is around 70 seconds after injection of contrast. Now, quick on oral contrast. This shows the bowel and is good for seeing leaks and obstruction, but it takes a while to work its way through the GI tract. So this is something you need to consider when it comes to the timing of the scan. Okay, here we're looking at a CT scan of the abdomen and pelvis that was obtained in the emergency department for abdominal pain. On the left, you can see axial cuts, and on the right, coronal cuts. The scan is taken in the portal venous phase, which is useful because most of the things that we want to see, including the internal organs, light up pretty well. Now, it's important to note that most software have windows that help you optimize visualization of specific types of tissue. Now, the most common types of windows you might see are bone, for instance, optimized here, lung, here, and soft tissue. Now, make sure you figure out how to toggle between these, because it can be very helpful for visualization of key structures. Now, I know a number of systems that I've used in the past simply use the numbers on the keyboard, 1, 2, 3, 4, etc., to toggle between these different windows. All right, now for the fun part. Let's play a little game of anatomy here. We're going to start by looking at these images, and as we scroll through, we'll rely mostly on the axial, but you can see the level at which we are operating by following this line here on the right side of the coronal scan. This patient, as you can see, is lying on their back, and their feet are actually coming out towards you out of the screen, and that makes this right actually left and the left actually right, and you can see that it's labeled with little R's and little L's. It is thoroughly confusing, though, and it requires some mental gymnastics in your brain to sort out right from left when it's switched like this. So we're going to play a little bit of an anatomy game here, starting with some simple observations. This here is the left lung and the right lung. Again, if I toggle between the different windows, I can see the lung images better. I'm going to go back to the soft tissue now. Here's the spine, and now to the bone window are ribs. And when we look for rib fractures, we want to scroll up and down and look at each area of the chest to ensure we're not missing any fractures. Here you can see the aorta, and there's a large vein that comes off of the central chest here called the azygos vein as well that you can see. Now I'm going to scroll down and note that we're looking here at the heart. Now, the heart will line up with the right ventricle pressed up against the sternum, so you always can look at this big area here and know you are at the right ventricle, which makes this the left ventricle, this the left atrium, and this the right atrium. Now, going back to the mediastinum, you'll see a bit of air here, so black is air. Anything denser gets more light, and you'll notice that the bone, which is white, is particularly dense, so that is much brighter than our lungs, which are full of air and are very dark. We have an air-filled structure here in the chest. That's the esophagus, and we can follow that down and see that the esophagus dumps off here into the stomach. All right, so back up to the top. We have our chest, our back, left lung, heart, right ventricle, always against the sternum, aorta, azygos, and esophagus. So we're going to move down now into the abdomen. We're going to see a few organs that pop up at this level. Big fella on the right here is the liver, up in the left upper quadrant, the spleen, and the stomach. These lines you see tracing along here and here are the diaphragm. And so you can see how they change as we scroll up and down. Now we'll keep sliding down, and we'll see a few more organs pop into the screen now. Here's the bottom part of our spleen. Here's the beginning of the upper pole of our left kidney, upper pole of our right kidney, and the pancreas. The aorta is still in the same place that we saw up in the chest there, just to the left of midline, and now we can see the IVC here filling just to the right of midline. We're going to come back to our vascular structures here in a moment. Here's the gallbladder underneath the liver. And as we scroll down, we lose kidneys here. And we're moving down into the lower half of the abdomen, full of bowel. And we're going to talk about differentiating colon from small bowel here in a minute. Here, your spine, your psoas muscles, and your pelvic bones. As we get lower, we can see the bladder and the rectum here. Let's go back up to the top and focus on the vascular structures. So again, this is a portal venous phase, which means we have the benefit of filling of the arterial system and to some degree the venous and portal venous system. So let's start here looking at the aorta. And as we come down, we're going to see our first branch of the aorta. First major branch is, you guessed it, the celiac. The celiac then branches into three different vessels. The major vessel here is the common hepatic artery. The major vessel branching here, right here, and it turns into a tortuous kind of twisty fellow, is the splenic artery. And the littlest one, which is hard to follow, which is right here, and you can see it's going to come around this way. The other direction. Here to here to here is the left gastric artery. So again, starting at the top, we have the first major branch of the aorta is the celiac. Trunk here has three major branches: splenic, common hepatic, and left gastric. All right, as we scroll down, there's going to be another branch. This is the SMA. It's just past the celiac takeoff. And this, we can see, comes down to the abdomen. It's going to start throwing off a ton of branches to the small intestine. You can see it start branching off and feeding the small intestine. In addition to feeding the entire small bowel, the SMA also feeds the right side of the colon. That's via the ileocolic artery, the right colic artery, and the middle colic artery. All right, so again, we have the celiac coming off here, SMA coming off here. SMA feeds small bowel and the right colon and proximal part of the transverse colon, and that includes, again, the middle, right, and ileocolic arteries. So let's follow our aorta down. We have two more branches here, one going off to the patient's right, to the right kidney. That's the right renal artery, and the left here, the left renal artery. And as we scroll down, we'll finally have our last major branch, which is the inferior mesenteric artery, which tends to be quite diminutive, which you can see right here, little tiny. And this feeds the distal transverse colon and left side of the colon via the left colic artery, the sigmoid artery, and the superior rectal artery. As we go farther down, the aorta branches and splits into the iliac vessels, the left common iliac vessel here, the right iliac vessel here. So let's follow the left side down. This is the left common iliac. It'll then branch into the internal iliac artery here, external iliac artery here. And as that passes past the inguinal ligament, it turns into the common femoral. The common femoral then branches into the profunda and the superficial femoral here, which runs down the leg. So let's go one more time from that branch point. And again, you can see this area here where we're branching to the right and to the left iliac. So let's follow down to the left common iliac, branches to the internal iliac, external iliac, cross the inguinal ligament, common femoral artery, branches to the superficial femoral artery, and the profunda femoris. All right, now let's look at the major venous structures, going all the way back up to the top. I mentioned before, we know this is the right ventricle. That makes this the right atrium. There's a huge vessel that dumps right here into the right atrium. That's the inferior vena cava, leaving the liver, traveling cephalad, and dumping into the right atrium. We can follow that back down to the liver. You'll see some vessels that are branching in, the hepatic veins. 1, 2, 3, that are dumping the venous drainage back here into the IVC before returning to the heart. We'll go back a little farther. Come down a little lower, and we'll see these large veins from the kidneys, the left renal vein, the right renal vein. Remember that the IVC is to the patient's right. That means that that left renal vein here has to be much longer and cross over midline to get to the kidney. And just like the aorta, the vena cava splits and follows the same type of path via the iliacs and femoral vessels. Now finally, let's look at the portal venous structures. Here we have a separate large vein, the portal vein right here, draining into the liver. And you can see the portal vein splits into its branches here. The portal vein is made up of a confluence between the splenic vein right here. This is splenic vein. And the superior mesenteric vein right here. So you'll see this is draining the mesentery, intestines, comes together here. Splenic to make the portal vein. Now, fair warning, the gastrointestinal anatomy can be a bit more difficult to sort out. We'll start up top here. The esophagus dumps into the stomach. So the stomach crosses from the patient's left side to the right side, where the pylorus becomes D1, or the first part of the duodenum, which is right around here. And the duodenum makes a C loop. It'll run here and then across, unless the patient has malrotation. Every patient's duodenum should go from the patient's right side across to the left side. And so we can follow it here. Right here is the duodenum coming across this way. We'll go in reverse now. Follow it back here, here, to here, back up into the stomach. After the duodenum crosses midline, it crosses through the transverse colon mesentery at the ligament of Treitz, where the jejunum begins. Now, in terms of tracing the small bowel, that can be really, really challenging. It's a lot of back and forth with your viewer to try to see if you can just follow that loop of bowel all around. A lot of times you lose it, and so that can be very challenging. It's a little bit easier when the bowel is dilated, like in a small bowel obstruction. Now let's get down all the way to the bottom and try to figure out the colon and its course. So to do that, the easiest way is to start down here all the way at the anus/rectum, follow it up, and at the peritoneal reflection, which is right around this area, around 12 to 16 centimeters of rectum, the rectum becomes intra-abdominal and turns into the sigmoid colon. And you see the sigmoid here. This is the S shape for sigmoid. This patient has not a very redundant sigmoid colon. Some people have these massive floppy sigmoid colons that go all over the place. This person does not have a redundant sigmoid colon, but we'll be able to follow this up. Here's sigmoid. And the sigmoid always goes to the same place as the descending colon on the left side, which is right in this area here. The ascending and descending colon are partially intraperitoneal and partially retroperitoneal structures. So you're always going to be able to find them in the same place right around here for the descending, right around here for the ascending, because half of the structure is actually parked in the retroperitoneum and the retroperitoneal fat. And so that dives down right here appropriately. Here's our descending colon stuck halfway into the retroperitoneum. Conversely, here's your ascending colon also stuck down. So you know they're always going to be here and here. So let's follow up now the descending colon. We're going backwards through the colon, backwards, and now we're starting to move across. Here, this is the beginning of the transverse colon. The transverse colon has no retroperitoneal components. It is all intraperitoneal. And so the best way to follow the transverse colon is to kind of slide your cursors back and forth and see if you can follow it. Here it goes here. Very decompressed, so not a big colon. Here, I'm following it across. It's kind of swooping down, you can see. There it goes there. Still following it across here to here. Back and forth with my cursor. There we go. And now that's the beginning of the ascending colon at the hepatic flexure. We're still going backwards. Now we're going down the ascending colon. There's the ascending colon, the cecum. And this is where small intestine plugs in as the terminal ileum plugs in to the cecum. Now, as I mentioned, this patient came into the emergency department with abdominal pain. If any of you caught the pathology in this scan, good for you. I'm going to show you now that this patient had appendicitis. And so this here is the appendiceal base. This bright thing is a fecalith, which is blocking the appendix. And this here is a dilated and angry, inflamed appendix all the way up to here. Now, one thing you'll notice, the inflammation, I showed you a previous image of a abscess with localized inflammation. You'll notice here that this fat is much more hazy in appearance, a little bit brighter in color. And that includes here in this area compared to perhaps here. That's all the inflammation from the appendix. There's no signs of perforation, though. I hope you found that useful. Now, get out there and dominate the day.